And this is a significant issue, as you know, in a lot of our head and neck patients, is the ability to eat and the ability to swallow. And so we're going to talk a bit about that, how to anticipate that and how to manage that. I do think that the next frontier in head and neck cancer is swallowing, is managing toxicities. Really, how do we use the tools that we have within as radiation oncologists, not just to anticipate toxicities, but how to mitigate them. And really, there's a lot of interest at many institutions, including ours, at looking at prehabilitation of these patients. So looking at a radiation plan and then designing, pre-treatment and intra-treatment measures to mitigate or to relieve some of the anticipated side effects that you expect of your treatment. And so we're looking particularly at the ability to swallow with a quantitative tool built into fluoroscopy called Swallowtail. And so that's a project ongoing there right now, looking at select patients. But for the most of us, really, it's the ability to anticipate side effects and the ability to manage them long-term. Today, we're just going to talk a lot about the anatomy and the ability to anticipate side effects in our patients. So the rest of my talk, as I mentioned, is really going to be talking about dysphagia and aspiration at risk structures. So you'll see that this is a new acronym called DARS. In fact, the trial coming out of UK is basically a DARS, modified intensity modulated radiotherapy trial, comparing at a specific attempt to spare these dysphagia aspiration at risk structures compared to a standard IMRT plan where you're not sparing these structures. So why does it matter? As I mentioned, just dysphagia really is a significant issue for many of our patients, both during treatment and really lifelong after treatment. And I will say that I think that it is a multifactorial problem. So, looking at the host, so looking at your patient and understanding, underlying comorbidities, other medical problems that predispose them to swallowing problems. And in particular, I would say looking at neurologic conditions that your patients may have. So we know that patients who have underlying neurologic conditions like Parkinson's disease or Lou Gehrig's disease really are very high risk for developing swallowing function after any radiotherapy. Similarly, looking at patients who have connective tissue disorders, so looking at patients who have in particular scleroderma, right? Scleroderma has been linked to patients having swallowing problems. So I think that that's something to always keep in mind. It's not just the tumor, where the tumor is located. Obviously, the location of the tumor and the decision to treat a certain area certainly has a lot of impact on swallowing dysfunction, but also understanding the underlying issues with your patients. But the two things that we can control as radiation oncologists is understanding what you contour and then how you plan and how you spare structures that don't need to be irradiated that can have a significant impact on patients swallowing. Other things that go into play, clearly, your treatment delivery. I'm going to spend just a little bit of time at the end talking about adaptive radiotherapy. This is, again, an area of a lot of interest, given the advances in our technology over the last, particularly over the last, 10 to 15 years, is looking at how we deliver treatment and looking at that image guidance piece, looking at what is actually being delivered on a day-to-day basis. And now there is a surging interest in really, adaptive radiotherapy. I think most of us at, many institutions, including I'm sure at yours, if you see a drastic reduction in the patient's, tumor volume and or weight, you have the opportunity to re-simulate them and re-contour them and replan them during treatment. There is, particularly with a new platform coming out with one of the new Varian machines called Ethos, there will be the ability to actually do continuous adaptive radiotherapy where you will be able to replan on the fly every day right before you deliver the treatment. And so there's a lot of interest in that kind of daily adaptive radiotherapy where you instead of having one or two plans over the course of 7 weeks, you literally will have the ability to conform your contours and your plans to the anatomy of the day and deliver a new radiation treatment plan daily. So that really is kind of the next frontier coming in terms of treatment delivery. And then finally, as I mentioned, rehabilitation both during treatment and after treatment, and a lot of interest in prehabilitation before treatment for these patients. So let's talk a bit about radiation-associated dysphagia. This has both kind of an acute phase, a chronic phase, and then a late phase. And so the acute phase, I think we're all familiar with, right? So it's basically the acute inflammatory effects that you see in your patients during the course of radiotherapy. And it's a combination of mucositis and xerostomia and pharyngeal laryngitis, which really leads to dysphagia in our patients. And as we all know, none of this is novel to you. You know that this typically starts, around the third week of radiation. It typically peaks at the end of radiation. And then particularly patients who are getting concurrent chemotherapy, especially if they're getting bolus platinum every 3 weeks, oftentimes the peak side effects are really a week or two after the last week of radiotherapy, because they're getting that bolus platinum dose at the last week of their radiation. In these toxicities, we typically think of radiation, but really there is a significant additive toxicity by adding chemotherapy in these patients. And this is not just cytotoxic chemotherapy like platinum or carboplatin or Taxol, but it's also immunotherapy. The classic thing that you see a lot with immunotherapy these days is just acute and late inflammatory effects in patients. And so certainly patients who are getting concurrent immunotherapy during their head and neck cancer radiation, we're certainly seeing both significant acute mucositis and then some delayed mucositis in these patients. But in general, when you think of recovery, as you know, most of our patients start recovering, about, in that second month after treatment. And that recovery, the significant portion of their recovery is in the first 2 to 4 months, after they're finishing their head and neck radiotherapy, in terms of regaining swallowing function in these patients. But as we all know, a patient's ability to eat is never quite the same after they finish treatment. So I think that, even with the best of radiotherapy plans, when you go to 70 gray to gross disease and take elective volumes to 50 to 60 gray, our patients are going to have some late sequelae of these side effects, which can last, months, years, and in some patients really lifelong. And these issues can really, we cure our patients very well in head and neck cancer, but it really does come at a cost. And the cost is this long-term survivorship living with these chronic side effects. And these side effects, can be related to, outside of the acute inflammation where you see chronic muscle edema, you can see chronic muscle fibrosis, atrophy, and strictures. And then there's this late onset, radiation-associated dysphagia that appears to be really related to delayed either mono or polyneuropathies of the lower cranial nerves that really help with the sense of swallowing. So cranial nerves 9, 10, and 11 and 12 often are the nerves that seem to play a role in some of our patients where they have these side effects. And what you see when patients have these cranial neuropathies is really the lack of pharyngeal propulsion, because of scarring of these swallowing structures. And so what happens is patients are just not able to swallow everything. So there is a substantial residue of food in your mouth, or really in your supraglottic larynx area, which leads to then sullen aspiration, and these patients get aspiration pneumonias. And we all know that aspiration pneumonia certainly is a cause of significant morbidity and unrecognized mortality in long-term survivors of head and neck cancer. I think that this is something that we as radiation oncologists just do not study very well. And I will tell you, particularly in the US, I don't know how it's in the Philippines, radiation is kind of an acute delivery phase enterprise, right? So most cancers, a radiation oncologist is following patients on the order of a couple of years. Even in the best of head and neck cancer programs, we follow patients up to 5 years, but at some point you're giving up these patients and they're now being followed by other physicians. And so I do find that most of us are just unaware of some of the long-term toxicities our patients undergo, after radiation. So let's talk about the OARs. As you know, head and neck is an area rich in many, many organs. And so when you're drawing these organs at risk, here I've kind of put in, here you can see on the left, you can see the organs at risk that are not typically associated with swallowing, but still very critical organs that have a lot of impact on function. You can see the temporal lobes of the brain, the optic structures particularly play a big role in nasopharyngeal cancers or skull-based head and neck cancers. And then, and on the right here, you see in the red, I've kind of put in all the structures that really affect swallowing. And so you can see that I have intentionally put some structures in bigger font and bolded them, because those are the structures I think really, really impact swallowing. But there are still other structures that impact swallowing, including your temporomandibular joint, your mandible, obviously your salivary gland and constrictor muscles, your larynx, really your supraglottic larynx plays such a big role in swallowing. and then your cricopharyngeus, your esophagus, but certainly also your oral cavity, and increasing recognition about these cranial nerves and vasculature that seem to also have an impact on our patient's ability to swallow.
Dr. Sangvhi?
Yes.
We do have a question. Is muscle edema the same as lymphedema? And what does it look like?
Oh, so I'm glad somebody asked that question.
Clinically and long-term.
Chronic edema of the musculature of the floor of the mouth and the intrinsic muscles of the tongue that you often see, and even edema of the supraglottic larynx. So I think any of you who have brought your patients in for, if you have a basal tongue patient, to give you an example, and you're bringing that patient to be scoped 3 months or so out after treatment, you will see that their epiglottis is significantly edematous post-treatment. That is a acute side effect of radiotherapy. Versus lymphedema, it really is occlusion of the draining lymphatics. And so I think the best area that you or the most common area where you see in head and neck cancer where patients develop lymphedema, as you can imagine, is kind of right here, right? I call it the turkey waddle, or, it's really submental edema. And you will see that often happens in patients where you're either irradiating their floor of mouth or the deep muscles of the tongue, or you're irradiating level 1 nodes, so level 1B and level 1A nodes, and you're basically causing, stricture in the lymphatic channels of the upper neck, and you will see that those patients will develop basically a turkey waddle. That's the classic lymphedema that we typically see in head and neck radiotherapy. So great question, but they're two slightly different things. So talking about xerostomia, so we know that we have these 3 major set of spit glands. We're very aware of this. It produces saliva, and as you know, saliva impacts lots of things. Besides swallowing, really affects our taste, our speech, and saliva has lots of important a role in our normal life, including digestive enzymes to digest some of the carbohydrates and fats, and as well as saliva also prevents dental decay by clearing a lot of the oral bacteria in your mouth. So if your mouth is dry, you're not clearing a lot of your harmful oral flora in the mouth, which then causes puts you at risk for dental caries and dental decay in patients. So when you think about saliva, you have 2 types of saliva that we think about. We all produce about a half a liter of saliva a day, but you have resting saliva, which is the saliva just when you're talking, when you're not just resting, you're not thinking of food, you're not chewing food. And when you think of resting saliva, majority of that saliva is produced by your submandibular gland, about 65%. And then the other glands contribute, somewhat to your resting saliva. And then when you think about stimulated saliva, so this is when you're actually thinking of food, or when you're chewing food and when you're swallowing food, your parotid gland really is the primary gland that produces, majority of your stimulated saliva. And you will see why this becomes important in just a bit. So you guys all contour the salivary gland very well. I actually went back and looked at some of your contours. I think most of you have contoured this really well. We know that when you think of the parotid gland, you have both a deep lobe of the parotid gland and a superficial lobe of the parotid gland. This is the accessory portion of the parotid gland, which basically is parallel to the to the masseter muscle right here. And oftentimes people forget to draw this accessory tail of the parotid gland. And there's a lot of interest in this region of the parotid gland because there's at least some intriguing data, particularly from British Columbia, that says that the stem cells for your parotid gland lie right here in the accessory tail. And so if you're able to spare this, which I can tell you that in most head and neck cancers, we can spare the superficial aspect of the parotid gland very well, right? Because the lymph nodes that you're treating are up here in this region. So the deep lobe, oftentimes is not able to be spared, but we're often, very good at sparing the superficial lobe of the parotid gland in these patients.
Dr. Sangvhi,
yeah,
go back a slide and maybe show with your mouse or a pen where the tail is that you're talking about?
Yeah, so here is that, here is that accessory tail. So here you see this, again, sorry about the dental artifact. You can see this patient has fillings right here. Here's that masseter muscle.
I don't think we see your mouse.
Oh, you can't see my mouse? Hold on 1 second. Can you guys see my mouse now?
Yeah, that's a lot better.
Okay, perfect. Okay. So again, showing you, so here you can see the mandible, here's that masseter muscle, and here's that accessory tail of the parotid gland. This is the one common pitfall that I find my residents don't realize to contour. They do a very good job of contouring kind of the superficial lobe, and Sometimes they kind of miss the deep lobe, but here's that accessory tail right there. And let me kind of show you on the next slide. Again, this is kind of a really good indication. So here you see that accessory tail of the parotid gland. And here's that arrow. I actually put an arrow here so you can see here's that masseter muscle, here's the accessory tail, here's the superficial lobe, and then here is the deep lobe. And we all know the deep lobe of the gland kind of traverses on the other side of the mandible. And basically, we all know there's no anatomic, a readily identifiable anatomic landmark that separates the deep lobe and the superficial lobe. It is actually the facial nerve, which unfortunately, we're not typically going to be able to see on a scan. But the surgeons know this very well. When they do a parotidectomy, these days we really, really try to spare that facial nerve. But you can see here, again, the deep lobe of the gland. And so here you can see the mastoid process, and then you can see the styloid, and here's the stylomastoid foramen right there in patients. So this is where that facial nerve ultimately goes in through the base of skull in these patients. And so here, we all know this. I'm not going to spend a lot of time talking about this, but we know kind of the landmark trial that really established the role of IMRT in head and neck cancer. And that's the PARSPORT trial, again, published from the UK by Chris Nutting. This trial came out in 2011, and this is the only trial of its kind to really look at 3D conformal radiotherapy and IMRT. So you can see I am old enough to have planned head and neck cancers with 3D conformal radiotherapy. I don't know how many of you do this on a routine basis, but you all remember you basically had these opposed lats treating majority of your upper head and neck, and then you had an anterior matched superclave field treating the low neck nodes. And you can see that, we never really contoured anything. I basically drew this on a port film. And, you treated everything. You clearly treated your cancer, but your salivary gland saw the same full dose of radiation that your tumors were seeing up in this location. And here you can see this is an old-fashioned plan. This is, again, looking at fixed field IMRT. And you can see that the isodose lines are now starting to bow in and spare that parotid gland on both sides. Better sparing on the left here, obviously. And if you look at the early results of the PARSPORT trial, it basically showed the mean parotid dose. So here, in the red is the GTV doses. So you can see that there's definitely better coverage with IMRT, particularly as your primary tumors start growing up towards the skull base. And this is why the only IMRT trial to have really shown an improvement in local control is in nasopharynx. And it's really because we were able to finally adequately dose tumors in these patients. But here's the salivary gland. So this is 3D conformal, radiotherapy. This is IMRT, and green is the DVH for the parotid glands. And you can see that there's significant sparing of the parotid gland here with IMRT compared to 3D conformal radiotherapy. And what did those results show? So these are just looking at that trial. And again, I just want you to kind of look at this. So red here is 3D conformal, blue here is IMRT, and then on the x-axis is time. So time from completion of radiotherapy, and then on the y-axis is proportion of patients who have either grade 2 toxicity or higher. So you can see this is going from 0 to 3 months. As you can see, everybody gets these acute side effects. So you can see that there's significant xerostomia acutely. And interestingly, with IMRT, because you're able to spare some of that salivary parotid gland pretty well, even there was a statistically significant difference in the proportion of patients who had grade 2 toxicity here. But what you see over time with 3D conformal, as we all know, is that there is almost no recovery of salivary gland function across time in these patients when you treat them with 3D conformal radiotherapy. And this is because, again, your mean dose here was on the order of, over 50 gray. So you were completely obliterating that gland there. Versus if you look at patients with IMRT, you can see that there is recovery of function. But the one thing I want you to keep in mind, so you can see even 2 years out, 24 months out, about 20% of patients still reported grade 2 or higher xerostomia, when looking at the RTOG scale in these patients. This is looking at patient-reported outcomes. So this is a EORTC Head and Neck 35 questionnaire that these patients filled out. Again, in red is 3D conformal radiotherapy, in blue is IMRT. And so you can see that there is, in the early phase, during the course of radiation and right after, there's really is no difference between 3D conformal radiotherapy and IMRT in terms of how miserable patients are. But as the patients start to recover from 6 months on out, you can see that patients who are treated with IMRT have significant recovery. But I still want you to kind of get a sense of, when you look at these scores, mean change of scores from baseline for dry mouth, even with IMRT, 35, 40% of patients are still complaining, that their mouth is drier than what it used to be prior to the onset of their radiotherapy. So IMRT for parotid sparing is very good, but it clearly is not perfect in these patients. Again, here showing you something similar. So what dose of radiation spares parotid function? This is looking at mean dose to the spared parotid gland. And you can see that when you keep that mean dose to the spared parotid gland somewhere between 0 and 25, 26 gray, you get, a recovery of that salivary gland function. So here in the black is 3 months, and then 12 is, in the clear here is 12 months. And so what you want to see is the relative salivary flow compared to baseline, and you can see that, that these separate out when the mean dose is somewhere between 0 and 20 gray. But once you start really going beyond mean doses of 30 gray, you can see, particularly 35 gray and onwards, that there is just really no recovery compared to baseline. So the patients are not recovering their saliva. Just to kind of give you an example, so here's one of my patients, treated for a base of tongue cancer, left base of tongue cancer. I'm treating bilateral neck nodes. He had bilateral neck nodes initially, and you can see, doing a really good job of sparing majority of the parotid gland. You can see here on the axial plane and then here on the coronal plane. And you can see that the mean parotid dose for both parotid glands on the order of 20 gray. So very good sparing of the parotid glands. But I would say that it really is time to start thinking beyond parotid sparing, because one of the things that you notice, and I'm going to go back to this patient, if I were to scroll down a little bit further in this patient, you would see that the submandibular glands in this patient are getting a mean dose of like over 50 gray. And that's because when you treat bilateral level 2A nodes, there really is no way of sparing the submandibular gland unless you're doing some IMRT planning gymnastics to be able to spare that. It's really, really hard because the submandibular gland is right anterior to those level 2 nodes. And here I'm showing you basically a terms of correlation of patient reported, xerostomia scores and submandibular gland doses. So you can see when the submandibular gland doses start going in the range of 50 to 70 gray, really majority of patients do not really have good salivary function. It's that same patient. So again, showing you this. So this is that same patient where you can see this big base of tongue tumor I'm treating. So in the red is 70 gray, the yellow is my 60 gray volume, and then my green is my 56 gray volume. And you can see that both submandibular glands are smack dam right where I would be treating around the base of tongue tumor. And you can see, my mean submandibular gland dose is really on the order of the prescription dose for the left side and 56 gray on the right side. So really no meaningful sparing. But what if you move the submandibular gland, right? So this is, again, another one of my patients, a very similar base of tongue patient, again. And you can see that this is a submandibular gland that has been surgically transposed by the surgeon about a centimeter-ish or so, centimeter and a half anteriorly into that submental space. And then, again, I've kept the same contour. So you can see unilateral tumor. I'm treating, this patient, basically you can see 70, 60, 56 gray volumes. Here's the 56 gray volume. But by moving that gland just a little bit, I'm really able to spare that submandibular gland. So here the blue is the 10 gray isodose line. And you can see it really nicely skirts right around the submandibular gland. So I think particularly for oropharynx patients, this is a big area of interest. Right now at UCSD, we're doing a feasibility trial here, looking at this, looking at xerostomia scores with both quantitative and qualitative xerostomia scores in patients with submandibular gland sparing. And our early data looks really good. So we're finding that as we were able to spare that one submandibular gland to a mean dose of less than 20 gray, they have a significant recovery of their xerostomia in terms of their patient-reported xerostomia outcomes. Is there any data for that? There actually was a phase 2 trial published initially in 2012 and then updated in 2018, which actually looked at exactly this. It looked at SMG sparing in patients, and you can see that when you looked at late xerostomia outcomes, percentage of patients reporting grade 2 or higher toxicity was down to 6%. And when you compare all of the other IMRT series here, you can see that that's typically, if you look at, when you just do parotid sparing, grade 2 xerostomia in most patients 2 years out or so, most reported outcomes are going to be, anywhere from 20 to 35, 40% in terms of the percentage of patients that will report grade 2 or higher xerostomia. So there's certainly a role for submandibular gland sparing in these patients. The
Dr.
next is
Sangvhi?
swallowing. Yeah.
Okay, so when you did the transposition of the submandibular gland, did you have to wait for wound healing before
Oh,
you
that's a
started
great
your-
question. So typically this is an outpatient surgery. Takes about an hour in the OR. And typically, for most patients, we simulate them within a couple of days of the surgery. And, then they start usually as, a week and a half or so out from their simulation. So not a significant delay in patients at all. So you can do this very well. The other question I get, the patients love to ask this question is, hey, can you move that submandibular gland back? We've generally not done that. It's kind of an ordeal to do that. And so, but there's a little bit of submental fullness that they will get because the gland usually goes right here in these patients.
And also, Dr. Sangvhi, there's another question like for Parotid. So some institutions, they only contour the superficial lobe.
It's great.
And you showed in your lecture that it's important to include the deep lobe.
Yes.
For computation. So what is the implication of that one?
Yeah, so that's
the mean dose.
If you look at some of the early RT trials, the contouring guidelines only really contoured the superficial lobe of the parotid gland and did not include the deep lobe of the parotid gland out of recognition that when you treat level 2 nodes, that the deep lobe is usually abutting where you're treating those level 2 nodes. I think that a good habit would be to contour the entire gland and then subtract your PTV. So here, we draw this, we draw basically the entire parotid gland, but I do then create a structural called parotid optimized, which is basically, where you contract your any PTV from the parotid. And I'll usually look at both of those structures when I'm evaluating a plan. So, certainly there are times where you will see that, particularly if you have a ipsilateral bulky tumor or bulky node, that we're not able to intentionally spare that parotid gland. But then when I look at the parotid minus PTV, we're still sparing a significant portion of the gland. So I think that, you really have to look at both of those volumes to see, are you sparing a meaningful amount of the parotid gland? Now, I think the question remains, what is a meaningful amount of sparing? If you spare 75% of the gland, if you spare 60% of the gland, and there's not really great data about this, but hopefully there will be soon, looking at how much of the gland do you really need to spare to call it sparing, when you can't spare the entire gland in these patients. But that's a great question. I think across institutions, there's still a lot of variability of whether you draw the entire parotid gland or whether you just draw the superficial lobe of the gland. And even here at UCSD, we had to, about 4 or 5 years ago, standardize the way we all drew the gland, because there was a lot of heterogeneity across all of our sites as to what people did and how people evaluated a plan. So right now, the way we evaluate a plan, we look at the entire parotid gland, basically, both contouring the deep and superficial lobes.
Okay, thank you so much.
Next part I want to talk about is swallowing, right? So, I could spend hours and hours just talking about swallowing because it is such a complicated function that we very poorly understand as radiation oncologists. But there are, just in general, there are 4 phases of swallowing: the oral preparatory phase, the oral transit phase, the pharyngeal phase, and then the esophageal phase. And all these phases, when you're swallowing, to give you an idea, we all swallow on the order of 600 to 1,000 times in a day. So we're constantly swallowing, whether we recognize it or not, right? You're swallowing saliva all the time. And swallowing is a very complicated function with lots of different muscles. So, your longitudinal muscles of the tongue, your circular muscles of the tongue, and then, other structures, your supraglottic larynx, your suprahyoid muscles, and your base of tongue. All these structures have an impact on swallowing. But the areas that most of us these days really focus on are the pharyngeal constrictor muscles, the longitudinal muscles in these patients. And you can take, you can go back and look at some of these. I've kind of put in some detail about what each of these structures do. But the best data when you look at swallowing function really comes from University of Michigan. Basically, this is an early study now, over 15 years or so old, that looked at swallowing function prospectively with video fluoroscopy and esophagography done both prior to treatment and then post-treatment in the acute phase and what they call the late phase, which was 6 months or longer after treatment. And what they showed, this is the first study of its kind to really show that there was a strong correlation between swallowing dysfunction, which was objectively measured by fluoroscopy related to the dose to both the pharyngeal constrictors and the glottic and the supraglottic larynx. And out of this initial trial, kind of came these recommendations to try to keep the mean dose of our constrictor muscles and the supraglottic larynx to about 40 to 50 gray. This is, if you guys remember, TD tables. So, 50, this is looking at, 5% chance of getting toxicity 50% chance of getting toxicity of 5 years, and this is 25% chance of getting toxicity at 5 years. So you can see that the delta is not very big. So you can see that, going from a mean dose of 56 gray to 63 gray, you're increasing that likelihood of toxicity from 25% to 50%. Similarly, looking at supraglottic larynx, that spread is a little bit wider, 39 gray to 56 gray. But generally, the rule of thumb is any midline structure, whether it's the constrictor muscles or the supraglottic larynx or the esophagus or the cricopharyngeus, most of us try, whenever reasonably possible, to limit that dose to about 40 gray, 45 gray or lower. Now, I will tell you that it's very hard to spare all structures in all patients, depending on the anatomy of where the cancer is located. These are just showing you these dosimetric predictors of swallowing function. So you can see this is some NTCP modeling. So you're looking at here, mean dose to the superior constrictor muscles and the mean dose to the supraglottic larynx. And you can see that, when you have mean doses that are low on the order of 10 to 30, 40 gray, the likelihood of complication is fairly low. But once those mean doses start going 50 to 70 gray, the likelihood of complication, increases in these patients, basically. Same thing for supraglottic larynx patients. This is, again, just showing you some of the Michigan data, again, showing you the mean dose to the supraglottic larynx and the likelihood of aspiration. And you can see that these are generally all sigmoidal curves that you're going to see, meaning that the likelihood of a complication when you keep that mean dose to somewhere between 25 and 40 gray is fairly low, on the order of 0 to 20%. But once you start really going beyond 50 gray, you can see that likelihood of complication increases significantly. And you can put any structure here, in any midline structure here, and you're going to see this very similar sigmoidal curve in these patients. Again, showing you here pharyngeal constrictors and looking at that NTCP modeling here. So you can see at 40 gray, very low likelihood, but as you start going to that 60, 70 gray, pretty high likelihood. And this is, video fluoroscopy, and these are all actually sonography, visualized aspirations in patients that you're looking at. Similarly, looking at quality of life outcomes. So these are patient-reported questionnaires that they're filling out. And these have also been correlated to the constrictor dose. So you can see here, when the mean constrictor dose is on the order of 30, 40 gray, the likelihood of complaining on a quality of life questionnaire is fairly low, versus when you start going up higher, it's higher. This is not nearly as perfect as objective criteria. So I also want to show you that there's a clear difference, in what you see and what patients perceive. Again, now looking at the same thing, this is now supraglottic larynx, the GSLS supraglottic larynx. Again, looking at, increase in aspiration and video fluoroscopy summary scores. So you can see, on the order of 20 and 30 gray, fairly low likelihood. But once you start really going beyond 50 gray, you can see that, much higher likelihood of developing aspiration. Same thing looking at these questionnaire scores, basically showing you kind of the same thing, although this rise is not as prominent in these patients. There's lots and lots of data now over the last 5 years or so that have really confirmed the initial findings of University of Michigan, looking at acute toxicity and late toxicity and correlating that to basically mean scores, of mean doses to the constrictor muscles and the supraglottic larynx. Those two structures have been validated the best across a variety of data, including, University of Michigan, MD Anderson, and really now more recently out of Denmark. So this is talking a little bit about the Denmark data. So I wanted to kind of show you what this contouring looks like. So you can see in the red here is superior constrictors, and the blue here is middle constrictors. Up in yellow here is inferior constrictor, base of tongue, supraglottic larynx, glottic larynx, cricopharyngeus, cervical esophagus, and esophagus. So you can kind of get an idea. It's literally this midline structures going from the, basically going from the near top of C1, base of skull, all the way going down, down into the head and neck. So I wanted to show you some data. And so this is this Danish data, which I find very, very intriguing. And so what they did was they looked at pattern of swallowing dysfunction in patients. And they divided it into these 5 groups of patients. Patients that have low persistent dysphagia post-treatment. And these are all long-term swallowing, by the way. Patients that have intermittent persistent symptoms, patients that have severe symptoms, patients that have transient symptoms, and patients that have progressive symptoms. And then here are all the organs that they basically track kind of mean dose to these organs. And think of it as a heat map, okay? So don't go dwell into all the details, but I want you to kind of get a sense of the brighter it is. So the more red you see is the higher the dose, obviously, and more likelihood of you having some kind of swallowing problem. So as you look at these heat maps, you can see that patients that have severe persistent dysfunction, tend to have a really high mean dose to lots of different structures here. So you can see, these mean doses are on the order of, higher than, close to 60 gray or higher, right? Versus patients that have low persistent swallowing dysfunction long-term, have better sparing of these structures. And we can get into the individual details later, but I just kind of want you to get this sense of how this is now predictive and prognostic of outcomes in your patients. And you can see that it's not just the swallowing muscles. Your salivary function has profound impact on your ability to swallow. So there's better recognition of this as we realize, and particularly you can see submandibular gland sparing is becoming more and more important in these patients. And again, kind of just showing you, so this is basically grade of swallowing dysfunction months after radiotherapy. And you can see this is kind of looking at their patients. So you can see that majority of their patients had just some low persistent swallowing dysfunction. But there were some patients who had this acute rise in transient symptoms. But there's a small but real minority of patients that have either progressive symptoms or severe persistent symptoms. And these are the patients up here where nerve injury really is thought to become the predominant pattern predominant cause of dysfunction in these patients. And I will tell you that we understand this very, very poorly today as to, how this nerve injury happens, or better yet, how to spare this nerve injury. But we do understand how swallowing is affected and what these constrictors, what the anatomy looks like. So I wanted to show you what this anatomy looks like. So here is basically looking at superior constrictors in these patients. So you can see you have the longitudinal muscles and the circular muscles. And so this is the superior constrictor right here. And so basically it's drawing this very thin band, 5 millimeter, band of tissue. And then here, obviously here you see the base of tongue in these patients drawn in orange. So this is what swallowing constrictor muscles and base of tongue contouring looks like in these patients. So again, up here, looking at superior, coming down here to looking at middle constrictors and base of tongue, and down here, looking at inferior constrictors, and then in magenta here, looking at the very top of your supraglottic larynx. So, most places now really make a concerted attempt to contour these structures and spare these structures. And down here, kind of again, looking at, here you're down your inferior constrictors, your glottic larynx here, and down here, you're kind of coming into the cricopharyngeus basically in this area in these patients. So the question that always comes up, hey, can you spare all the DARs in all the patients? Obviously not. The answer to that is no, right? You never want to compromise dose to your tumor to be able to spare swallowing function. So, when you think of superior constrictors, you typically cannot spare that in nasopharyngeal cancer patients, right? So by the time you contour that entire nasopharynx, the superior constrictor is going to be in that volume. You can't spare superior constrictors also in patients when you have any pathologic retropharyngeal adenopathy in those patients. In other patients, though, you really should make an attempt to at least spare the medial retropharyngeal lymph nodes. There is very good data to suggest that outside of nasopharynx and perhaps hypopharynx patients, very few patients ever fail in the medial constrictor muscles. So even when you feel that you have to treat you have to treat the retropharyngeal nodes, you really want to treat the lateral retropharyngeal nodes, and you can spare the medial retropharyngeal nodes, and that way you'll spare the superior constrictor in these patients. In terms of middle constrictors and supraglottic larynx, clearly you cannot spare that in any patients when you're treating base of tongue tumors that are going down into the vallecula or any supraglottic laryngeal cancers. In terms of inferior constrictors, you can't spare those in patients when you're treating laryngeal cancers or hypopharyngeal cancers. Obviously, the decision to treat unilateral neck versus bilateral neck has profound impact on swallowing. So when you have that early stage tonsil patient that has a very well lateralized tumor that is not invading into the base of tongue and has minimal soft palate involvement and minimal or no nodal disease, really the decision to spare that unilateral neck is going to have profound outcomes in your ability to spare their swallowing function. Similarly, for a well lateralized, oral cavity patient or a paranasal sinus patient, you can certainly think of sparing the contralateral neck in those patients. Just showing you what this contouring looks like. So here's a patient of mine. Again, that same patient I showed you earlier, base of tongue patient. And you can see that up here is, we here actually cheat. We kind of draw all the constrictors as one structure and then arbitrarily kind of divide them up by the vertebral body for the dosimetrist as superior, middle, and lower. And so, but you can see here drawing that, right? So here's that superior constrictor muscle drawn in. Up here, you can see clearly not going to spare it. And down here, again, trying to spare it. So here you can see the glottic larynx and then the cricopharyngeus start being drawn in. And you can see that the plan now, this same patient, you can see that we've really made an attempt to now spare the midline here up higher. So the superior constrictor muscle is spared fairly well in this base of tongue patient. But obviously, we're not sparing the middle constrictor and the supraglottic larynx in this base of tongue patient because we need to treat the tumor in here. And then inferiorly, we're now sparing the inferior constrictor slash cricopharyngeus and the glottic larynx in this patient down here. So you can see that, you can certainly, do that kind of sparing. And this is the UK DARS trial, just got presented last week, right after I gave my talk to you guys at ASCO. Basically looked at exactly what I mentioned. They had basically, a standard IMRT versus dysphagia associated, a structure sparing IMRT, and patients were randomized to one or the other, included all patients. And they basically had very similar philosophies. So if you had a, base of tongue patient, you were asked to spare the superior constrictor. If you had, a tonsil patient, you were asked to spare the middle and lower constrictor. So it depended on based on the location of the tumor. And the early results look pretty promising. So basically, the patients who got this dysphagia modified IMRT plans had better sparing of the inferior constrictors and the superior middle constrictors compared to the standard IMRT plan. These are mean doses. So you can see that, about 30 gray to about 50 gray, and here about 50 gray to versus 60 gray. And the primary outcome actually being tested in these patients was basically patient-reported swallowing dysfunction, and they used the MD Anderson dysphagia inventory scores. And early results definitely show that patients that had dysphagia-sparing IMRT had better MDADI scores to date. So I think this is kind of the next ground, particularly in radiation, is really mitigating toxicity and really planning with toxicity in mind, particularly in oropharynx patients, but in all patients, right? But particularly in your HPV-associated oropharyngeal cancer patients, and I would also argue in your nasopharynx patients where your cure rates are so good. This becomes really important. Last couple of slides is just about planning, right? So right now at most places, I imagine you as the residents do all the contouring, and either you have a dosimetrist or a physicist who then designs the plan. And we all know that our plans are as good as the contours we draw, as good as the constraints we give them, and finally to the experience of the planner, right? All these three functions there's a lot of variability in this. Our goal with this course is to standardize contouring in decision-making in terms of how to spare organs. But we still have this big unknown of your dosimetrist and your physicist in terms of planning. So there's a lot of interest now in what's called knowledge-based planning, where instead of a human doing all of the planning part, you have computer programs written that can auto-plan based on the contours you give them. This is something that one of our physicists here has really worked on. So I will say at UCSD, majority of our plans are knowledge-based planning plans, meaning that once we draw the contours, It's processed through a software, and the software spits out a plan, and then it actually goes to the dosimetrist to fine tune that plan. And what we find with knowledge-based planning is that we are getting a much better consistency in our planning and consistency in meeting our objectives in terms of sparing function in these patients. And so this is just some math slides, but what I want to show you is just the effect of knowledge-based planning in terms of plans. So this on here you can see is basically the quality of plans, terrible plans, okay plans, amazing plans. And this is when you see just that you have different dosimetrists at different places doing all the planning at UCSD, and this is when you use knowledge-based planning. It really just shifts objectively the quality of plan to a much better plan. And I'm gonna relate this to really DARS. This is probably where we have had the best gain, is in sparing these dysphagia-associated structures. So again, here, what you're looking at is basically on the blue is knowledge-based planning. So where the plan was processed through this computer software versus manual planning. And you will see that the biggest gains, the biggest deltas that we have to date have really been in the area of swallowing issues. So we can see the esophageal sparing is much better. Pharynx sparing is slightly better, but that's where and really the cricopharyngeus and larynx sparing is better. So you can see the asterisks here are just where there was statistical significance. So you can see that really in dysphagia associated sparing, the more auto planning that you are able to do, the better it'll be. So I'm going to stop there, and then I want to switch over to going over some of the contours that you guys very nicely did. Okay. Yes.
So before Dr. Sangvhi proceed to the contours, are there any other questions that you want to ask, or any clarifications?
Yeah.
Oh, sorry. Was someone else speaking?
Oh, I have one more question.
Yes, please.
So what is the tolerance of the parotid minus PTV? Is it the same
it's the
as
same.
your
That's
parotid?
a great question. So there's really no difference in sparing. I think what I look at often is the volume of the gland being spared, right? So I pay a lot of attention. So I will tell you, because, this is all I do every day, I have a pretty good idea of what the parotid gland should. So everybody's parotid gland is, by the way, very different. So you will see that some people, as I call, have for my medical word, very juicy parotid glands, where the volume of the parotid gland is on the order of 30 to 50 cc's, versus some people have very atrophic parotid glands, where the volume of the parotid gland is on the order of 15 to 20 cc's. But on average, if you look at parotid glands across, on average, the average parotid gland should be somewhere between 30 and 35 cc's. So then you want to look at, hey, how much of that gland are you sparing? So if I feel like when I look at that, parotid minus PTV volume, we call it our parotid OAR volume. If it's 2/3 or higher, you've done a good job of sparing the gland, right? So that's what I typically look at. So, versus, if say that in an atrophic patient where their gland is 15 cc's and the spared gland is 3 or 4 cc's, clearly, over 2/3 of the gland is completely being irradiated to a high dose. You're not going to spare salivary function in those patients. We're in the process of looking at that actually to see if we can come up with kind of a magic number to show you how much is enough in terms of sparing, and then trying to correlate that with the anatomic portion of the gland being spared. As I said, the data from British Columbia about having that accessory portion of the parotid gland where it parallels the masseter muscle is very intriguing. So if truly the stem cells lie there, if you spare that, are you improving salivary function? So we're in the process of looking at that right now. So.
Okay, thank you for that, Dr. Sangvhi. Ben, you were about to say something?
Thank you, Dr. Sangvhi. I just wanted to summarize knowledge-based planning. Is that doing planning with your physics team and having conversations about the relevant?
So knowledge-based planning is basically a software. Ultimately, it's a software. So actually, Varian now sells this, by the way, and it sells as part. If it's an option that you can buy off of Varian for a variety of disease sites. And basically, what it does is it takes a library of plans as a background, and then plans your particular patient based on the library of plans that it has in there in terms of understanding what the sparing should be. So it's basically, for us, we built our own library of plans. So we looked at a couple of years of our patients that were planned manually, and then looked at what those, looked at good plans, bad plans, okay plans, and then took the good plans and then kind of designed this software to basically, it says algorithm basically to improve sparing. So it's all completely automated. And so it's basically a code, and these codes can be written generically, where you can, basically, which I think Varian is selling now, or you can make them institution specific. So you can actually look at your library of plans and look at your best spared plans and create appropriate software to your cohort of patients.
I see. So does it look at what the toxicities were for that patient?
This was all based on just dosimetry. So it's not actually correlating to toxicity yet. So this is all purely dosimetric, looking at just sparing and how you prioritize sparing of all these structures. So.
Okay. Well, I think one take, even if we don't have knowledge-based planning at our institution, it shows that we can do a better job.
Well, absolutely. I think that, right, most of us, don't have knowledge-based planning. So I think I see somebody just sort of question. I've said that middle constrictors and cricopharyngeal muscles associated with acute dysphagia versus inferior or superior associated with late dysphagia. Yeah, so I will say the data for this is really, really mixed. But I will say that classically, if you look at University of Michigan, MD Anderson, and the Danish work, classically, the two structures that have probably had the most correlation with dysphagia have been the middle constrictors and the supraglottic larynx. I think that those have been consistently shown to have an impact on dysphagia. I think superior constrictor muscles, they all kind of have impact on dysphagia. And I think that that's what's going to be the next iteration of studies, as we are now going to consciously spare these structures. What we should look at is, you can look at cohorts of patients and look at what you spared, how much, and then correlate it to long-term outcomes. So, I think the interesting question, I think the next step to me for this DAR study really is, hey, does it matter whether you spared superior constrictor versus middle constrictor versus inferior constrictor? Or does it matter that do you need to spare one or two of them very well and sacrifice one of them because you're treating the cancer there? Or sparing all three of these structures to some degree matters? So I think that we really don't know that yet, as to what that degree of sparing needs to be and how much across the board. So that's what I would say. Okay, so here, can I want, let me share this. Is this, can you guys see?
Yep, looks good.
Okay, perfect. So this is a T2N3 nasopharynx case, although I think this is more like a T3. This is a bad nasopharynx. And so I will tell you, very interesting, we only gave you the CT. And I will say that this is where having an MRI would be very, very helpful, or a PET scan would be very, very helpful, because this patient has really, really bulky adenopathy. And so I was looking at a variety of your volumes. And so I'm going to say that, so I think that number 17, I don't know who that is, but I think that number 17 did probably the best jobs here of contouring. So I will say, looking up here, right? So this is a patient that clearly, if you look at just CT based, right? So if I don't have the luxury of having a PET scan or an MRI, when I start looking at the CT, clearly there is a fullness here in the infratemporal fossa right here. And so here you can see, here's kind of the, the maxillary sinus, and here's the very beginning of the pterygopalatine fossa and the pterygoid plates, right? Very beginning of the pterygoid plates. And you can see that there's clearly this fullness here that is not here, which at first I was like, is this just the way the CT slices where the patient is slightly tilted? But as you look inferiorly, you realize that you really have this very bulky nasopharyngeal cancer. So here you see torus tubarius, right? And you can see this tumor is arising out of this fossa of Rosenmuller, going through the medial and the lateral pterygoid musculature, and really is actually going beyond the lateral pterygoid musculature down here. So this actually is all real. And then you can see, just looking at the contrast enhancing stuff, very good job. This is going all the way out to the mandible. It is clearly, going across the posterior pharyngeal wall of the nasopharynx and crossing across midline. And you can see this is all tumor. And you can see it's going all the way to the pterygoid plates. and then here it becomes kind of hard to know if it is crawling along the soft hard palate junction or not. Here you can see that's why that physical exam would be really important to be able to look in somebody's mouth and see that. But this is all tumor. And here you can see that there's probably an RP node here that is just directly contiguous with the nasopharynx, right? So you can't really see that. But these contours are really good. I thought that this was really good here. Still some fullness here. Probably I would have added a couple of more slices here. But what I want to talk about is this node. This is like the world's worst nodal disease, right? So you can see that here's this parotid gland. And so here's basically, you can see skin, subcutaneous fat. Here's the very top of the masseter muscle right there. This darker stuff that you see, sir. So, this density, parotid glands are made of fat. And so that density is much closer to fat than it is to muscle. So here's that very top of the parotid gland. This is all tumor that has grown into the parotid gland. And this patient has disease going all the way to the mastoid and the occipital condyles and going back. So if I were to show you this, I would have contoured all this as nodal disease. And I know this seems a little hard, but again, one slice lower, you can see all of this as cancer, right? So this is all very, very bulky nodal disease. So you can see that even though we teach you, nasopharynx cancer goes into the RP nodes, level 2 nodes. Here's the sternocleidomastoid starting to come in down here. Down here, it can certainly grow into the deeper musculature of the neck here as it has here and going all the way towards the spine in this patient. This is all disease. So here you can see here, compared to the contralateral side here, you can see here, retropharyngeal space right there, constrictors right there. You can see level 2A nodes, level 2B nodes. Here's that sternocleidomastoid. You can see why being skinny does not pay in head and neck cancer, right? The fatter you are, the better you can contour, because that subcutaneous fat is so helpful in discerning between tumor and normal anatomy. So when you have somebody who's so skinny, it's very challenging. But you can see, but this patient has no disease on the contralateral side. And you can see that these are the deep musculature here, cervical musculature, and you can see this is all tumor. And so I think that number 17, you did a great job of contouring. Pretty much really most of this you contoured very, very well. I thought this was really well done. I would have contoured these nodes a little bit lower. You can see that here they start becoming cystic, but these are still nodes. This is still GTV, GTV node right there in this patient, okay? And then now you're kind of out. But you can see no fat. This is like my nightmare to contour nodal basins when there's absolutely no fat, and I have to treat this level 5 space right here for a nasopharynx patient. Makes it really, really challenging, but you have to treat it there, because if you don't treat it there, cancer, as you can see here, grows very nicely. And you can see, again, sternocleidomastoid muscle, the muscle ends there. This is really that 5A node right here, 2B 5A node right there in here. So great job here. And then let me see, I wanted to see if I could pull okay, this is number 17. I don't think you have the CTV volumes drawn in here, but your GTV volumes look good. But I do want to spend a little bit of time kind of talking about, let's see if somebody's drawn in these volumes. Let's see.
If you click on the eyeball on the right, yeah, maybe click on a different structure, and then you'll be able to click the eyeball. Yeah. Okay.
Okay, so I will say, I think it's a really good habit, especially when you're in your early days of contouring, that you contour the intermediate risk CTV for your primary separate than your nodes. Because I always want this to be kind of an exercise for you as you're drawing the CTV, the intermediate risk CTV around your primary tumor. You need to, for each case, think, what do I need to exclude? What do I need to include, and what can I safely exclude, right? So for this patient, I would say, I would have called this a T3 personally, and I will say that I would have started a little bit higher. I would have, in this patient, treated bilateral cavernous sinus. I would have treated the posterior half of the ethmoid sinus, and then certainly treated all of the sphenoid sinus right here. Ben, I don't know how to draw on
here. So click the paintbrush at the top, right there, paint.
Oh, there we go. Oh, perfect. So I would have done this something like this. Okay. And okay, let's see. how do I add? Okay, let me get off here.
You can push escape, yeah.
Perfect. And then when you come here though, right? So now let me turn on those really nice volumes from number 17. Okay, so here you can see this is where no textbook is going to show you how to draw this. None, right? So let's see, if I were to take this, let me see if I can do this. But you know now in this patient here, okay, this looks good. But here, here, you need to include the entire infratemporal fossa in this patient, okay? There's nothing to be spared here. You need to now cover all of this in this patient because this patient clearly has disease going into the infratemporal fossa. So I think so this is where this would look something like this, okay, for my primary tumor. And then I would have clearly included this in my nodal contours, but again, here I would say all this looks good, but here I would be very, very generous, including all of this. So again, going up cranially, as I mentioned, I would have covered the cavernous sinus here. I would have covered clearly the sphenoid sinus here. I would have covered this just because I think this is just an advanced case. Okay, you could certainly make the argument here to spare the pituitary gland right here, but here I would have covered this. And then here is really where I would have started to cover this infratemporal fossa on this side, because clearly this patient's tumor grew there, right? So you need to cover all of this. So again, no textbook is going to teach you that. You're never going to see this in a textbook, right? And the other thing I would say, coming down here in this patient, I would have covered more of the clivus and I would have covered more of the skull base. So let me see if I can change the windowing. Okay, perfect. So when I am trying to cover the skull base, I always change this to bone windowing so that I can actually see the cranial nerve foramina very well. So on here, it's hard to see, but foramen rotundum is somewhere right here, okay, right in this area. And foramen ovale is right in this area, okay? But in this one, given how much tumor is on this side, I would have covered all the foramina on this side. So I would have come here to really cover the jugular foramen in this patient. So here I would have made this way more generous. Okay, versus this side, I would have kept exactly these volumes that you did. So here, let's see. Okay, all of this. Okay. And then this looks great. So coming down here, again, I'm just kind of paying attention to the volume you put around the primary tumor. So I can see that, you know, you covered, you know, the soft palate here, you know, so that's perfect. I think all this looks great. And I think one of the things that I often find that my residents love to do, they love to have these volumes look very, very symmetric. They feel compelled that the right side should look exactly as the left side. And I always have to tell them there's no reason for that, right? So for here, where you know this tumor is so dominant, you know, completely on the left side, you can certainly have this be more generous on this side and less generous on this side. You do not need to keep this symmetric, right? You need to kind of have a sense that this patient is going to fail. I mean, this doesn't have to be this generous, but this patient is going to fail much more likely onto the soft palate on the right, on the left side versus the right side. So you need to be more generous in your coverage there in this patient. And then for the nodal one, if I were to do this, I know you guys drew everything kind of as one structure. You can see that here you're going to have to really cover all of this stuff out here and cover, this is a case where you cannot spare the parotid gland, right? So you have to treat all of this parotid gland and some of the preauricular space. So the only thing I would have done, I would have certainly come off of, let's see. All right, let's see if I can draw this one particular slice. So here I would have done something like this, okay? So I would have covered all of the stuff, and particularly if you think that there's parotid invasion, this is a patient that needs bolus, right? you need to put bolus on here to make sure that, especially when there's invasion into the superficial lobe of the parotid gland, you have to put bolus there to make sure that this patient gets good dose. Now, I will say with a VMAT-based plan, this is somewhere up for debate, because when you're using a VMAT plan, you're generally getting a lot of good, pretty good dose even without bolus, even when tumors are pretty close to the skin. But I would have put bolus in here in this patient. And these nodal volumes, again, no atlas is going to show you, but you're completely right. Like, this needs to go all the way back here and treat this very generously. So you're not just treating level, RPs 2 and 5 nodes, but you're treating this huge mass with some margin on this mass. And I would have probably taken this all the way to the vertebral body here. On the right side, these volumes look really good. If anything, I'm going to come down a little bit here. So again, because level 5 nodes go pretty far back. And I would say that in this patient, the only other thing here, I would have definitely made the call to cover 1B here. In this patient, since if there are no level 2A nodes on the right side, I would have tried to spare the submandibular level 1B nodes here. That would be the one difference that I would have done. But I would have covered the nodes here. So I think this looks great. So I would have basically stopped. Let's see. I don't know if it's shipped.
You can erase when it's red by clicking.
Oh, there we go. Okay.
Or if you hold down, I think, Control or Option when you click.
Yeah, there you go. Okay, so here's what this would have looked like. And here, we make a couple of points. So RP nodes start literally at the base of skull, and they go all the way down to the top of the hyoid. So great job here. Great. So my residents always miss this. They will always want to spare right here to spare the constrictors. But in a nasopharynx case, you really can't do that. So this is really good. So treating, yeah. So I would have done this. And then once I come to the hyoid, I would have done exactly what you're doing here. So yeah, this looks good. This looks really good. And then down here, obviously, I think you guys did a great job. I think the hardest part is the 5B coverage. And I will say that in a nasopharynx patient, I'm very generous about 5B coverage. And so I probably would have treated a little bit more posteriorly in these patients. I just feel like there's not a lot of toxicity by covering 5B here. And then in terms of dosing, I would say that, I would have probably, if there were no level 3, on this side, there is a level 3 node right here, right? But if on the contralateral side, there were no level 3 nodes, I would have treated the contralateral supraclav and 5B nodes to 54 gray. So these are minor changes, right? In terms of what dose do you give down here. But I would have tried to spare this brachial plexus better and just gone to 54 gray on the contralateral low neck in this patient. But I think this was, generally very well contoured. But you can see nowhere will you find that you have to treat all of this. But this is a case where you have to treat the infratemporal fossa because of just this tumor growing right out through here. You can't see the planes very well. There's a nice and healthy fat plane here between the torus and the musculature. There's just no plane here. And then when you come down here, you can see this very necrotic tumor that truly is going past the lateral pterygoid musculature here. So definitely a very bulky tumor.
And Dr. Sangvhi, can we turn on the other GTVs so we can see what maybe how other people did? And
yes, let me turn everything off, and then let's see. So JC, I don't see JC nodal volumes. Do I know? Okay. Oh, J1. Let's do J1. Okay. So here you can see, again, I will say that I would have really needed a MRI or PET to make sure this is all tumor. But again, here I was not very convinced, but then once I started seeing here, I'm pretty convinced this is all disease here. So I would have been more generous here. Good job here on the nodal contouring. Clearly you got the node very well, and you contoured you contoured this occipital portion of the node. So this all looks good. And then it's hard to tell. I mean, these are all just, I think all of the GTVs, including the nodal GTVs, and all this looks great. I mean, I think you guys got the nodal GTV really well, except here, again, this is just, this tumor growing into the parotid gland is most likely a node that has just grown all the way out into the parotid gland. And it's not uncommon, I'm sure you guys see this, that very locally advanced nasopharyngeal cancers certainly can present with parotid gland involvement. I have several cases where, as I mentioned, half my nasopharynx cases are actually when they recur, because we don't see very many nasopharynx cancers here. So when they come back from other places, and I usually see 1 or 2 cases a year where the patients have failed in the parotid gland. And what it is that I find that the the prior planners and the treating physicians have just been very super diligent about sparing the ipsilateral parotid gland. And that's why I think those patients then fail there, so really if you should, in most head and neck cancers, particularly in nasopharynx cancers, especially if you have a bulky nasopharynx tumor and bulky ipsilateral neck adenopathy, really trying to spare the ipsilateral parotid gland should not be your priority. You should really just try to spare the contralateral parotid gland and not worry about sparing this, because when you get really acute here, that's when you start missing and seeing recurrences in these patients. So yeah, this was a tough case, but see here, I would have just contoured in terms of this nodal volume, it really needed to be like this. You can see that. And then the question becomes, once you have a node that is growing into the parotid gland, how much of the parotid gland do you need to treat? And I will tell you, there's no consensus on this, right? Some people will say, oh, just like everything else, put a 5 mm margin on for your CTV70 and treat that. But then the question becomes, since you don't, in your elective nodal volumes, you don't typically cover the parotid, what do you do with that parotid on that side? I would err on the side of treating the entire parotid to some dose, whether that's 54 gray or 60 gray. Once you have parotid invasion, there are no anatomic boundaries within the parotid gland. And so I think that you really have to, condemn yourself to treat that ipsilateral parotid gland to at least 54 to 60 gray on that side.
Dr. Sangvhi,
yeah.
One of our residents is asking, would you have given induction chemo for this case?
Absolutely. That's a great question. I think I would have given induction chemo for this patient. Yeah, I think that's why this patient was called N3 nodal disease, because if you look at the craniocaudal volume of disease, it's certainly bigger than 6 centimeters. And I would have given induction chemo for this patient, really for 2 reasons. One, I think if you look at the data, really, and this is across, I am not a huge believer in induction chemotherapy in general for non-nasopharyngeal cancers, but the place I do think it has a role, one, in nasopharynx patients, if they have either very bulky primary tumors or bulky nodal disease, because I think that really their risk of distant disease is just so high, it inherently makes sense to start with induction chemo in these patients for 2 reasons. One, to decrease that risk of distant disease, and 2, to make your job as the radiation oncologist a little bit easier. So hopefully you get some contraction. And then the question would have come, right? So what if you treated this patient with induction chemotherapy and now there's no nodal disease in that parotid gland, right? Could certainly happen. Say the person has a great response to induction chemo and that nodal disease really involutes. I would say that you still have to treat that parotid gland, right? So then I think the question becomes, what dose are you going to treat something to? And I will say that I think that's really the art as to what happens. So I see the follow-up question. If you've got induction chemo, would you treat the pre-chemo GTV or CTV or the post-chemo volumes? That's a great question. So I think for the nodes, it's very easy. For 70 gray, I would only treat the gross, whatever the residual nodal disease there is, to 70 gray. I would make sure that I treat wherever there was initially involved nodal disease in my high-risk nodal CTV. So meaning that volume would all get 60 gray at least. Now, I think the harder part becomes, what do you do in the nasopharynx? Do you treat where you initially had disease, or do you treat all of the disease? This is hard. I honestly, I don't know that there is an easy answer to this. Clearly, whatever you can see on your post-induction treatment planning CT that looks like gross disease, you're going to go to 70. There is one school of thought that if at all reasonably possible, you should treat all of the initially involved areas of the nasopharynx to 70 gray. And then there's this other school of thought that you should just, only treat the gross disease to 70 gray and then really cover all of the other uninvolved nasopharynx to 60 gray. I will say that this is where I probably come with an intermediate dose cloud. So I often will do, a 70 gray volume that is truly to gross disease post-induction. And then I will do a 66 gray dose volume. So, I'll do 2.12s times 33 to the gross disease, 2 gray times 33 to the initial pre-chemo gross primary disease, and then 1.8 times 33 to the big elective volume around the nasopharynx. So I would just add another layer of dose. So I feel like 60 gray is too little, and 70 gray to this huge area where there's no visible cancer may be too much. So 66 gray, like a microscopic, like ECE dose gray, right, seems just right. And it'll help you, spare some of the structures, especially your brainstem, better in those cases. So, all right.
Oh, sorry, Rochelle, you're muted.
Oh, thank you. This is a very interesting day. And I know, time flies so fast.